So just to give you a quick overview of the inpatient part, because I was asked to speak more about the outpatient part, just wanted to share the inpatient part because it really proves the point that when you really aim for 100% or close to 100% achievement of evidence-based medicine, then you can eliminate disparities. You improve the quality of everybody. And so our results were for all recommended care for acute myocardial infarction. So that was all of those indicators I was telling you about, the aspirin, the beta blockers, the PCI, all of that. We actually had a statistically significant improvement from 91% to 100% over the course of the study period, which went from the last quarter of 2005 through the last quarter of 2007. And for heart failure, we had even a larger improvement from 72% up to 97%. That took a lot of work and a lot of coordination, and it all paid off because when we looked at our how we did with eliminating disparities, we compared to our baseline data. Now, just so that you know, all of the 10 hospital systems in the Robert Wood Johnson Foundation Expecting Success Project went through the same training to make sure that we had the same standard data collection for race and ethnicity and language data, where the patients self-report and we have specific categories. So all of us had the same categories that we were collecting data for our patients. And when we did our baseline data, we were surprised by what we found. We found that with one of the indicators, which was the aspirin on arrival, we did better with whites than blacks. But then look down the next two. We had two of our heart failure indicators, the one where you have to check the left ventricular function, and the other where you actually treat with ACE inhibitors and ARBs for left ventricular systolic dysfunction. We were doing better with blacks than whites. And then with another one of the indicators, the smoker cessation counseling, we did better with Hispanics than non-Hispanics. So we had this interesting set of data. On the one hand, we were a little bit relieved that we did not have the typical type of disparity, but anytime you have disparities, you feel a little bit uncomfortable because you don't know what's causing it. You don't know what's going on. So we wanted to eliminate those disparities as quickly as possible, and we decided, as I said, to really, really emphasize quality improvement. And within 6 months, and then continuing through the end of the project, we had no racial or ethnic disparities. All was eliminated because of the improvements in the quality that I showed you before, where we were close to 100% compliant with those indicators. Interestingly enough, our CEO of the healthcare system got really interested in this and said, you know, well, there's also talk about women not getting the same level of care for cardiac disease. Can you please check our gender data? And so the Robert Wood Johnson Foundation statistician was very helpful and actually analyzed our data for us. And we had no disparities on gender either, so we were really happy about that. So for the inpatient part, we came up with these key elements for success. And I'll just go through them as quickly as I can because I want to move on to the outpatient setting. But I think they're important because some of you may be working on inpatient projects, and they're even applicable to the outpatient. Physician champions are really important. Having physicians who understand and embrace evidence-based medicine and serve as a model for their fellow physicians and also for the teams, the medical teams, gives you a huge boost in how quickly you can make these changes. And then you need to have administrative support to make sure you have the right resources and that everyone's held accountable. We have to have multidisciplinary teams, so you got to get all the stakeholders around the table. A good example of this was our door-to-balloon times, that PCI piece. That was very challenging because our ED was on the first floor and our cath lab was on the third floor, and the patient has to go through all of this maze of things that they have to have done, and our cath team does not sleep in the hospital, so they had to be called in if it was after hours or on weekends. So all these things we had to coordinate, and we had to make sure that it happened within 90 minutes or less. So we got the ED, the cath lab, and the quality department all together. We had physician representatives and nurses, administrators, and staff sitting around the table, and we developed a PCI task force. And we met weekly and kept looking at our data. What we did was we divided all the steps that the patient has to go through along the way, and we gave people in the different departments responsibility for those. So even though 90 minutes is the final amount, the ED only had 10 minutes to get that first EKG, and so on and so forth. And we divided up 45 minutes for the ED, which included the travel time to the cath lab, and then 45 minutes in the cath lab. And even if we achieved the 90 minutes, but someone fell out in their sub-segment, we held them accountable so that we were continually doing process improvement. And in the end, we ended up with a code heart program, a code heart process, where the patients come through the emergency room. Even the front line staff that are not nurses, they're just, we call them PCAs or medical assistants, were trained how to just look at patients, and even if they're not clutching their chest in an obvious way saying I'm having chest pain, to know what other atypical presentations patients could have. And those frontline staff initiated the EKG right then and there, takes the EKG to the physician reads it. All that has to happen in 10 minutes. And so it sets off the clock running. The patients were literally running, you know, on the stretcher with a clock, counting down the time. And all along the way, everybody is being held accountable. Everyone's paying attention. And we ended up doing things in parallel instead of in series. So once the ED doctor says this is an ST elevation MI, we have to activate the code heart process, the hospital's operator did a blast page overhead and to everybody's beepers and cell phones, so everybody on the team gets notified, including even the transportation people who helped to take the patient. Everything was thought about. We had special access for the cardiologists to come through a back door after hours so that they didn't take any extra time. We were trying to shave seconds and minutes off of this whole process. Everyone worked together and achieved remarkable results. We went from 67% compliance at the 120-minute mark. Initially, CMS had a 120-minute mark, and midway they even tightened up and made it 90 minutes that you had. And by the time the end of the project, we were at 95% average, the 95% compliance. And 6 out of those last 12 months, we were at 100% compliance, which is just amazing. Watching everybody come together was just fantastic. And when you look at that, there's no room for disparities. If you're hitting 95 to 100% compliance, you're not going to have disparities. So that was the beautiful demonstration right there, how you bring everyone together and you can accomplish this. Everyone, as I said, was accountable, and we were following what we call SMART goals. And down at the bottom, I have this. We learned this from Robert Johnson, that all the goals we were measuring were specific. They were measurable, actionable, relevant, and time-specific. So we didn't say, oh, we want to do better at PCI, for example. We said, no, we want to make sure that we have 100% compliance with our PCI times by December of 2007. And everybody understood that, and we were tracking our data along the way.